The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, hope everybody's having a great summer. I wanted to do a quick podcast before I left out of town, and we started a series back about 2 months ago where we looked at inodilators, we looked at pure vasopressors, and I wanted to finish off that series and look at inodilators. And inodilators are something that I get asked a lot of questions about, specifically Dobutamine. So this podcast will be pretty short, 8 to 10 minutes. It's going to be very focused on Dobutamine and Milrinone. Although Milrinone isn't seen very much, it's used quite a bit in the neonate population, pediatrics with congenital heart defects, pulmonary hypertension, things like that. So I'll hit on that, but we're going to probably pretty much focus on Dobutamine. We'll kind of dive in, and I'll give you an example of why or when you were going to use this, and then we'll kind of look at the pathophysiology. Let's say you have a patient that's a 68-year-old male patient, history of cardiomyopathy, cardiogenic shock, and you have hemodynamic numbers in front of you, CVP of 16, cardiac index of 1.3. He's got a pulmonary artery diastolic and systolic of 44 and 26, actually a systolic and diastolic of 44 and 26. He's got a pulmonary capillary wedge pressure of 27, and he's got an SVR of 2100. So remember, your CVP is going to be probably the telltale signal of what's going on. If it's low, you're volume depleted. If it's high, most probably you're going to be overloaded. Your cardiac index is an indication of cardiac output. Remember, cardiac index is based on body surface area, and we know cardiac index is between 2 and 4. So just right there, you can tell that we actually have a low cardiac output. Pulmonary artery pressure, systolic and diastolic, is 44 and 26. That's significantly high. And your capillary wedge pressure is 27. So one of the things I always try to teach when I teach hemodynamics is your CVP, if it's high, your wedge pressure is going to be high. If your CVP is low, your wedge pressure is going to be low. And they should mimic each other, I would say 9 out of 10 times. And then your SVR, remember, is all about squeeze. We want our SVR between 8 and 1200, and it's actually 2100. So this is a classic left systolic dysfunction. This patient probably is going to have a poor blood pressure, and they have a poor blood pressure for a few reasons. One of the biggest reasons is the cardiac output is poor. The cardiac output's poor because you have a left ventricular dysfunction. You're not getting the ejection fraction. You're not getting the ample blood pushed out like you need. So what can we do to help that? The SVR is through the roof, right? We've got compensation, it's through the roof. But you need a medication that's going to actually reduce the SVR, and it's going to actually increase the contractility. So that's where we kind of jump into inodilators. And our specific inodilator that we see and we use is Dobutamine. Remember, Dobutamine is very, very good. It's got great inotropic, and it's got chronotropic effects, but primarily inotropic effects, very, very good contractility, but it also causes a vasodilation. So this is going to be your go-to medication in any left ventricular failure, any pulmonary vasoconstriction, high pulmonary vascular resistance, and then really low cardiac output states. One of the things you have to understand, though, with Dobutamine is because of that vasodilatory effect, you always want to make sure that your tank is full. You never want to give this medication to a patient that hasn't been volume resuscitated. So always make sure this patient has fluid or volume in their tank, and then you can give that. And always the rule is, most often you want that systolic, or you want that MAP to be, in that 65 range, 60-65 range. But you will use this on people that are hypotensive. And this is a classic patient. You have a patient that's in profound cardiogenic shock. They have an SVR through the roof. That SVR is actually causing an impedance on allowing that left ventricle to contract appropriately. This left ventricle has either got a restrictive or a dilated cardiomyopathy. It's either it's just not working effectively, and so now it's having to pump against even more resistance. Now, we don't want that. So let's look at dobutamine really quickly. Dobutamine, again, is a catecholamine. It's got beta-1 effects. It's got primary inotropic effects. It does have some mild chronotropic effects. Again, always want to watch for patients that are severely hypotensive. You always want to make sure that you have another pressor. So if you were going to give this to, let's say, a septic shock patient that has profound hypotension despite fluid, and you had neosynephrine on board, or again, your primary pressor of Levophed, and you put this on, always make sure that pressure is high. But when you're talking about a cardiac patient in cardiogenic shock, again, sometimes maybe that SVR is so high and that left ventricle is not working appropriately, and that's why your blood pressure is low. And dobutamine is going to be very, very good in that situation. This is kind of one of those things where you just have to trust the medication. It kind of goes against everything that you're taught as far as giving a medication like this is going to vasodilate. And a lot of times patients that are in CHF, you would also give, let's say, a nitro drip. And a nitro drip would be given in that context for the same reason, because that patient has an SVR that's so high, that's causing an increase in impedance, it's causing more pulmonary edema, more pressure against that mitral valve, and the nitro is going to work on both preload and afterload. It's going to reduce those vasoconstrictive, pulmonary vasoconstriction and things like that, and it's going to help relax. So dobutamine does the same thing. So always try to fill the tank. Remember, even if a patient's in cardiogenic shock, pulmonary edema, that doesn't mean that they can't have volume, right? Give 250 cc's at a time. Make sure the tank is filled. Dosing is 2 to 20 mics per kilogram a minute. And remember, this is going to work very, very good. It's going to first cause a primary vasodilation. That's going to help open things up. It's going to reduce that SVR, and then it's got that inotropic effect. It's going to increase the contractility. So we've reduced the SVR. Now we're going to allow that ventricle to contract even better, more efficiently, and that's going to increase that cardiac output. So that cardiac index on this patient, you would start seeing that increase, and that SVR is going to drop down. You should also start seeing that pulmonary capillary wedge pressure drop. Remember, a pulmonary capillary wedge pressure is all about left ventricular and diastolic pressure. And when we've learned, and I've taught this in review classes and on other podcasts, that diastole, the whole diastolic aspect of your cardiac cycle, is the most important. The whole point of your pulmonary artery is to maintain that diastolic pressure. So we don't want huge increases in your diastolic pressure. We don't want the heart to have to contract against high pressures during diastole, because remember, diastole is a heart at rest. If we go from there and we go to Milrinone is something that, again, you don't see. I've only flown or transported this a few times. I know that they use this quite a bit in neonates with heart defects that are causing pulmonary hypertension and things like that. But remember, Milrinone is a medication that's a phosphodiesterase inhibitor. This medication is very similar in makeup of Viagra and Cialis, so it causes a profound vasodilation. One of the things it also does, it affects cardiac myocytes, and it leads to an increase in intracellular calcium. Because of the increased calcium, remember, calcium is a very potent anion, positively charged, that increases contractility, works on vascular tone, and things like that. So you're going to have an increase in myocardial stroke volume. That's going to cause a little bit of myocardial oxygen consumption, but you need that inotropy. That inotropy is going to be a good thing. Not going to really cause that big of if it at all, any change in heart rate. So you would use this in like a fourth line medication as far as profound cardiogenic shock or CHF. Other medications aren't working. Patient that's in profound pulmonary hypertension. They've used this in patients with pulmonary embolus that have had a right ventricular failure because of the pulmonary embolus. And we did a podcast a couple months ago ago on pulmonary collapse. And if you haven't heard that podcast, I go into the aspects of our low pressure side, our right side versus our high pressure side, and how that right side cannot handle the increased effects. So the pulmonary hypertension is a big deal, and that's where Milrinone would come in. And again, they use this quite a bit in the pediatric population, like I said. Not something you're probably going to see very often. You start with an infusion of 0.25 milligrams per kilogram, and then you're going to titrate that at 0.125 micrograms per minute in increments up to 1 mic per kilogram a minute. So those are your primary inodilators. Again, dobutamine is your primary inodilator. And again, if we look back at this patient and your CVP is 16, remember again, that is the indication of volume status. If that's all you had, if you were flying a patient with a central line, then, hook that up and get that waveform, because that's going to tell you a lot of things. So we hang this dobutamine, you should see that cardiac index increase, because now we have an increased contractility. We have a vasodilatory effect. That's going to decrease the SVR. It's going to allow that heart to contract more efficiently. And then you can augment that with other medications, give Lasix, you can give other medications that are going to help this patient. So hopefully that was helpful. Check out other podcasts. Check out the other podcasts if you haven't listened to the Pure Vasopressor, the Inopressors, and things like that. We discussed dopamine. We discussed Levophed being your primary pressor. We discussed the dopamine aspect of the new literature, evidence-based practice, and how, most literature is saying to stay away from dopamine. It's very good in the initial cardiac patient, but it's not going to be your primary pressor anymore. Levophed is going to be that primary pressor. Then we looked at pure vasopressors. Pure vasopressors are going to be your neosynephrine. It's going to be your vasopressin, and then the new one, methylene blue, and we discussed that in the literature there. So check those podcasts out. Again, I want to say thank you to everybody. If you haven't listened to the Second Shift podcast, been getting a huge following on that, so we're very appreciative. If you haven't, check it out. It's a time for Mike and I just to bring new people on the podcast. We talk about new trending things. We joke around. We play around, just kind of like we're sitting there on shift. So pretty cool. Again, I want to thank everybody for following FlightBridgeED and for making this one of the most amazing experiences of my life. We are up to 189% increase from last year in our downloads on the FlightBridgeED podcast, and that is just mind-blowing to me. So thank you for sharing the podcast with your friends, with colleagues, and just promoting our company. We really appreciate it, and I'll always be indebted. So again, reach out to me by email, send me emails, ideas for podcast cases that you've had. If you ever have any questions clinically, please email me. I'll try to answer them. If I can't answer them, I will always try to seek out that answer and get you the right answer. So again, on behalf of all of us at FlightBridgeED, I want to thank you, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.